Thank you. I am Dr. Mostafa Aziz Sumon. Welcome you all in today's case discussion. As you have informed, that this is the first ever SARC Radiation Oncology Symposium jointly organized by Oncology Club, Bangladesh, and Radiation Knowledge, a US-based organization. In the last two episodes, we have discussed the academic points. Now, in this session, we will discuss the lifetime case discussion. And I would like to request all the participants, because this would be the case for your planning competition. So let me introduce, I am Dr. Mostafa Aziz Shumon, working as Assistant Professor and Head of Department of Oncology, Kurmitra General Hospital. And beside this, I am working as a consultant in United Hospital, a private hospital of Bangladesh. So without any delay, we would like to proceed with this case discussion. So this 42 years old female patient presented with a lump in her left breast for 2 months. On examination, it was found that this mass was around 2 into 2.5 centimeter. The location was upper outer quadrant of left breast. No axillary lymph node was found. Ultrasonogram breast with axilla reported almost the same. It was around 2 into 2.3 centimeter mass in left axilla without any adenopathy, followed by ultrasono-guided core biopsy, and it comes with invasive duct cell carcinoma, grade 3. Immunohistochemistry was done, and it comes with a strong hormone positive with HER2 negative, Ki67 30%. So with all these informations, the tumor board decided for breast conserving surgery with sentinel lymph node biopsy. Considering her age and other factors, 4 cycles adjuvant chemotherapy was advised with AC, and thereafter whole-based radiation therapy with boost and extended hormone therapy was advised. So with this advice, he was underwent a wide local excision with sentinel lymph node biopsy, and post-operative histopathology comes with 2.2 centimeter mass, grade 3 infiltrating duct cell carcinoma. All the surgical margins are clear, no LVSI, and node is negative. So ultimately, it comes with a stage 2A disease, immunohistochemistry, luminal A, strong hormone positive, and Ki67 30%. So as we don't have the opportunity for the oncotype DX, considering her age, high grade Ki67 30%, she advised for 4 cycles chemotherapy, and she has already received 4 cycles chemotherapy with doxorubicin and cyclophosphamide. And after completion of the chemotherapy, she is now referred to a radiation oncologist for radiotherapy. Regarding the radiotherapy, the radiation oncology decided for whole breast radiation therapy with boost, as the axilla was clinically negative, so no regional nodal irradiation. And dose moderate hyperfractionation scheme was selected, 40 gray in 15 fraction with boosted tumor burden with 10 gray in 5 fraction by photons. And considering the techniques, we opted for 3D CRT and free breathing, because we are not very much familiar with DIBS technology. That's why free breathing technology was advised. So in the next few minutes, we would discuss keeping all these things in mind, and the point of discussion of my presentation, why the patient was opted for breast conservation therapy instead of mastectomy, why there is a role of radiation therapy after breast conservation surgery, and if we are opted for radiation therapy, what is the role of this boost, and how to localize this boost area. And there is a dose scheme 10 to 16 gray. So which patients for which dose, whom we should give 10 gray and whom we should give 16 gray. And sometimes it is said that the photon or electron may be advised. What should be the ideal technology instead of photon or electron? So I think we should take a advanced opinion. We should take expert opinion from our chairperson, Professor Aziz Marganti, regarding these issues. After that, we'll discuss the fractionation, because there are conventional, moderate, hypo, more hypofractionation stages are there. So which one to pick? As you have seen that whether there are some areas who can be avoided with this radiation therapy. That means, is there any group who can really avoid this radiation therapy? That means the de-escalation. And of course, the organ at risk and toxicity will be discussed. And at last, we'll discuss about the techniques, which is a very interesting area of discussion. So first, come to the point that the breast conservation therapy versus mastectomy. So as you know, in Bangladesh, we have what I should say that we have failed to popularize it. Still, most of the surgeons are preoccupied with the idea that the mastectomy is a better option. And the fear of the patients also forced them to take the decision for mastectomy. But this is a very interesting paper. It is assumed that the breast conservation surgery is non-inferior to mastectomy. But this Dutch paper published in 2016, this is a population-based retrospective analysis among 37,000 patients. And you can see, and they have found that 58.4% breast conservation therapy versus 41.6% modified radical myocyte. There's a huge number of patients. And finally, they have found that breast conservation surgery is better than mastectomy in respect of overall survival. It's a very interesting findings. But the question is why? There are different hypotheses, but the most accepted hypothesis is that the subcutaneous lymphatics, which are not addressed by surgery, probably radiation therapy is the answer. And this radiation therapy might be deal with this subcutaneous lymphatics, and this may be the answer of this increased overall survival. But the message is very clear that breast conservation therapy not only non-inferior, but it is better in respect of overall survival for some groups of breast cancer patients. So this is the paper which was published in the year of 2007. You can see the Philip Portmans, the former ISRO president, Maria Cardoso and Gentilini. They have jointly published this paper that the less is more. Breast conservative might be even better than mastectomy in early breast cancer patients. And they have mentioned a statement that sometimes patients demand a mastectomy driven by fear. But we have to give them information that the breast conservation therapy might be a good option for them in respect of overall survival. So breast conservation therapy not only non-inferior, sometimes it is better than mastectomy. So what is the need of radiation therapy after conservation surgery? Here you can see this is the early breast cancer trialist collaborative group meta-analysis published in Lancet Oncology 2011. And they have included 17 trials, more than 10,000 patients were there. And they have concluded that giving radiation therapy after conservation surgery to whole breast, you can see the 10 years, they can reduce recurrence by 15.7%. And by 15 years, the breast cancer related mortality by 4%. So they finally conclude that if you can avoid one just regional local recurrence, 4 regional local recurrence, 10 years, you can avoid at least one breast cancer death at 15 years. So this is the elaboration of that study. You can see that VCTCG's meta-analysis published 2011. These are most of them are pathological node-negative disease, early breast cancer. You can see that the breast conservation surgery only the result of recurrence 10 years 35%, where with the radiation therapy it is around 19.3%. So there is a 15.7% reduction of local regional recurrence by giving radiation therapy. And when you come to see the breast cancer related death, it is around 4%, and it ultimately reflects in overall survival. If you see the forest plot, you can see that the breast conservation surgery followed by radiation therapy is better in comparison to every variables, whatever the age, whatever the grade, whatever the size, whatever the surgery. In every aspect, that breast conservation surgery plus RT is better. So there is no question about giving radiation therapy after breast conservation surgery. So we have decided to give whole breast radiation therapy. But why this boost? What is the role of this boost and how to localize? And I have already mentioned what should be the dose or what should be the energy, whether it's photon or electron. This is the paper which was published in 2015 in Lancet Oncology by Bartel Link. He's a very famous person in breast cancer management, particularly for radiation therapy. Here you can see this red line is the no boost and this blue line is the boost. So for those who are less than 40 years, you can see the hazard ratio of locoregional recurrence is 56. That means almost 50% reduction in ipsilateral breast cancer recurrence rate. For 40 to 50%, though the line is not very far, but still it is significant. So this boost is definitely giving better result considering the ipsilateral breast cancer recurrence. For 50 and 60 years, those it is not very significant, but we can state it that those are younger groups, the boost is an additional tools to reduce the ipsilateral breast cancer recurrence. There is another study, that is the URTC study. It is a randomized control trial published in Journal of Medical Association Oncology 2017. You can see that the hazard ratio is more than the Bartel link. You can see the hazard ratio here is 0.37, and they have concluded that the absolute disease reduction 16% at 20 years, particularly for younger age with DCIS. So probably we have got an idea why this boost. It gives 50% relative risk reduction for particularly for the younger age group. But those who are more than 50 years, should we avoid radiation therapy for them? The answer is no. There are some specific subgroups, those who can benefit from this boost, or they are the grade 3 tumors, extensive DCIS, if there is lymphovascular invasion positive, triple negative tumor. So if there is non-radical surgical excision, we should opt for surgery. If surgery is not possible, then we should give the additional radiotherapy. But probably these are the groups whom we can give some additional dose, that 16 Ks. So localized boost area is really a tough job here in Bangladesh, because most of the times we did not see any surgical clips. But in the real world, during the surgery, surgeons used to keep a radio-opaque markers over there that is called the surgical clips. And by seeing these surgical clips, you can get an idea where was the tumor. So during the contouring session, this can help you to guide the area. But if the surgical margins are not there, the seroma area we consider as the tumor bed, and we use to this seroma area as a localization marker during contouring session, during contouring. Now come to the point of the fractionation. There are different types of fractionation. There is the conventional, moderate, hypo, more hypo. Which one to pick? You can see that the moderate hypofractionation, the conventional fractionation, 40 to 50 gray in 25 to 88 fractionations, with 1.8 to 2 gray per fraction, with typical boost to 10 by 10 or 16 gray and 2 gray per fractions per day. But this is the traditional. But after the moderate hyperfractionation schemes become so popular, now it is endorsed by all the societies, and they try to make it popular among the practitioners. You can see the shorter fractional schemes, that the 40 gray in 15 or 16 fractionation is now a popular choice. You can see this is the ESMO guidelines. It is level 1 evidence-based, and the recommendation is level A recommendation. You can see that the UK STAR trial, here you can see that they have compared with the conventional fractionations with hyperfractionations, that is the 40 gray in 15 fraction, that means 2.67 gray per day, and the total treatment duration is 3 weeks. And regarding the locoregional recurrence rate, these are very much comparable. This is the same dose that tried in the Dutch trial. They have treated the same. They have treated with the same dose, but the Canadian trial they have tried with the higher dose, that is the 42.5 in 16 fractions, that is the 3 weeks and 1 day. But these are all comes with the equal locoregional recurrence rate. So these are the evidence which helps us to give us the confidence regarding the practice changing concept from the conventional fractionation to hyperfractionations. But as we are going with dose per fraction, increased dose per fraction per day, we are really concerned about the toxicities, that is the cosmetics. And you can see the START-B trial, they have compared with the cosmetics purpose, and they found that the very comparable cosmetics. But if you go through in details, you can see that at least the START-B trial, the breast shrinkage, considering the breast shrinkage, you can see that the breast shrinkage is better with hyperfractionated, and it is statistically significant. Not only the breast shrinkage, breast edema is better with these 40 gray fractionations compared to conventional fractionation. So considering the breast cosmetics purpose, hyperfractionated is not only non-inferior, sometimes it is better in some cosmetics issues. So we have now decided for moderate hyperfractionations. Now, still we are 3 weeks dose duration, 3 weeks duration treatment. So, is there any other option? So we can compress this treatment duration any further shorter. So these are the studies, that is the fast forward trial, and they have tried with conventional fractionations, that is the 5 weeks treatment to 5 weeks, but one day per week with 6 gray, and 1 weeks per day, 1 days per weeks, and with 5.6 gray. Total duration will be 5 weeks. And you can see that the first trial regarding the toxicity issues, it is significantly high. But you can see the fast forward, which is published in the May 2020. They have tried with the conventional moderate hyperfractionation that is routinely practiced right now. That is the 14 gray in 15 fraction. They have compared 5 into 5.4 gray in 1 week. That means every day 5 gray, 5-day treatments, total 27 gray in 1 week, and 26 gray in 1 week. That means 5 gray, 5.2 gray in 5 days. Total duration is 1 week. And you can see regarding the locoregional recurrence, these are all equals, and the normal tissue compliance. You can see that this 26 gray in 5 dose is not significant. So this might be the area. Where the radiation oncologist are looking forward to see what should be the dose fractionation. So should we really convert our practitioners' practice from moderate hyperfractionation to some more extreme fractionation? Now come to see the de-escalation. De-escalation, you can see from these pictures that during the course of time, with the advance of surgery and the advance of radiation therapy, since 1980s, the rate of locoregional recurrence are decreasing. In the 1980s, it was around 30%. In 1990, with the advance of boost, you can see that the lines are lesser than the earlier years. And in 2006, the young boost trial, those who are very high risk group, you could see the locoregional rates is very low. So is there any groups whom we can really avoid this radiation therapy? There are some trials they have tried to find out this answer. You can see the CLGB trial. They have tried that BCS plus tamoxifen plus DCS plus tamoxifen RT, and they found that the local regional recurrence rate is high if we are going to avoid this radiation therapy. The Canadian trial is also find the same result, but the BASO2 trial they have tried that the breast conservation surgery, the local regional rates at 10 years is 22%. But for if we consider it for 1 year, that is that if we give radiation therapy, only breast conservation surgery, then the recurrence is around 2%. If we give radiation therapy or tamoxifen, the recurrence rate is around 1% per year. And if we give all, then this is really less, really less. So these trials did not find a decision, but some trials are ongoing. So to find is there any group whom we can really avoid this radiation therapy. You can see there are some single arm trial. They have tried to find out some biomarkers, that is the Ki67 oncotype DX or any other biomarkers, keeping these things in the calculation whether we really avoid this group from radiation therapy. And there are some randomized control trial. I hope these trials will give us this result in the course of time. So organ at risk and toxicity. The main aim of this radiation therapy is to maintain excellent local control as well as the overall survival, as we have already mentioned. But at the same time, we want to reduce the toxicities because radiation therapy comes with some toxicities, breast shrinkage, fibrosis, raised pain, edema, poor osmosis. Definitely there are some issues. And of course, for the left side of the breast, coronary events is a major area of concern. So you can see this is the paper which was published in New England Journal of Medicine in 2013. Here I can show that they have shown that with the increase of the mean dose of heart, the cardiac events increases. So we really need to check this during this radiation therapy. Now come to the most important thing, that is the techniques. So as you know, there are different type of techniques. I mainly want to highlight the heart because the heart is the major area of concern, particularly for the left breast. There are different technology to reduce the heart dose. The deep inspiration breathhold technique is one of the most emerging technologies and very popular. Respiratory gating is another option, but it needs some high-tech technologies. Prone positioning is one of the good technique, particularly when it's a very large breast. Proton therapy, but in Bangladesh, we are not in a position to discuss these issues. And there are partial breast irradiation, and of course, the IMRT or VMAT technology are there. For DIBS technology, you can see in free breathing, a very part of the heart is within the high dose regime. But when you are using this DIBS technology, you can see that there is a space between heart and this high dose regime, ultimately resulting a good cardiac mean dose. Supine and prone position, definitely in supine prone position, the breast is outside the heart. The breast is outside the heart, and it gives a comfortable zone to treat the patients during in prone position. So there are some there are some dosimetric comparison between this technology, 3D CRT, forward IMRT, VMAT, and you could see which I want to mention there, that even with the good 3D CRT, you can have a very good dosimetric results even with the 3D CRT and field technology, fielding technology. So who doesn't have any VMAT technology or IMRT or the very other fancy technologies, and they don't think themselves poor, as because if they can use this 3D CRT technology, it might have very good tools to give a optimum dose to the breast. Here is another dosimetric comparison between free breathing and breath hold. As you can see, with breath hold, the dose to all of the critical organs is really good, particularly for the heart. And in the VMAT, in every aspect, it is superior, except the contralateral breast. But those who are very younger age, we should keep it in mind that the contralateral breast dose is a major area of concern. So we really should focus this area. So at last, this is the recommendations. You can see that all other endorsing societies, that is Astro, Istro, ESMO, and they have endorsed that postoperative art is strongly recommended because it reduces the local recurrence as well as the breast cancer related mortality rate. And boost is strongly recommended because particularly for those younger than 50 years and some other groups, those who are 50 years. So I would like to request all the participants to participate in the planning competition and try yourselves and show us that even the 3D CRT can be a better option for a optimum dose delivery for a late breast cancer patients. Thank you all.